are very interested in having a discussion on how we use the devices when we are going to do bifurcation. What is the capability of a good workhorse? Some of them are the crimp profile, how is the diameter when we need to cross lesions, and what are the stiffness if the vessel is tortuous and you need to, well, have a bend pretty close to 90 degrees through a stent. What is the trackability, the crossability, and the pushability? And of course, when we do all these works with the stents, how is the polymer reacting? And is the coating capable of being intact after all the manipulation? The main vessel is most often tapered.
So the requirements for left main stent, going to mix with them with the requirements for bifurcation stent. But even the left main stents, I think they have the special subset of procedures. Talk about the large diameters, and especially the large overexpansion capabilities are necessary. If your proximal LAD is 3.5, you might want to go up to 4, 5, or even higher in the left main area. That's more than in an LAD diagonal bifurcation. Osteostenting, usually a standard practice of our left main treatment, and it was already known for many years that this area has, of course, different patterns in your wall construction, and that's why you need the highest radial strength you can achieve in this area. And I think there is a reason to think about thin struts, which have the fastest and best coverage in a rapid moment. Also, this time to coverage is important because in general our left main PCI patients are significantly older than non-surgical patients. And the higher bleeding risk is especially for these elderly patients, and they prefer a shorter duration of DAPT. So our average vessel diameter in this segment, in the non-diseased left mains, was 5.6 millimeter. And only 13% of the patients had a left main smaller than 5 millimeter. What are the labeled diameters which you have allowed? You can see that our friends for this sponsoring session, Synergy and Promise Premier, have the largest labeled. We just started this session with 5.75 as official labeled diameter. So coming back to the title, the requirements for left main stenting, large diameter. I think that we now have data up to 6.2. We know the radial strength is very high for this stent. Earlier we discussed that the radial strength is maintained at these high diameters. To introduce and update you on the ideal left main, which is then improved drug-eluting stents in an all-comers left main trial. It has two objectives. It's an objective where we have a short-term angiography and a long-term clinical outcome after implantation of this newer generation stents with a shorter dually plated therapy. We selected 4 months as a DAPT therapy versus the 12 months on the stent with the permanent polymer and a little bit thicker strut in an all-comer setting of unprotected left main. Dr. De La Torre, this is an example of the Synergy with this abluminal coating. And you can see this already only 2 months and see how fast it is covered. And I think we can hope to show that we can do safely that in a left main with a short DAPT therapy.
So this is really looking at the Celtic bifurcation study, which is currently recruiting. Using the Synergy stent versus the Zion stent in 111 Medina classification, bifurcation lesions, non-left main stem. And the plan's 170 patients, non-inferiority and primary endpoints at 9 months, looking at a composite of myocardial infarction, stent vessel failure, and stent thrombosis with angio follow-up. Simple approach seems to be best. However, the consensus did state that in cases of bifurcation with large side branches with osteal disease extending more than 5 millimeters, a 2-stent strategy could be utilized. A improvement for the complex strategy, but certainly not beating the simple strategy. However, the peri-procedural MI, as we've mentioned, was a big factor for the 2-stent strategy. So I suppose the question is there still a role for further improvement? And we certainly can see that potentially improved technique, better application of final kiss, better sizing. So there is certainly the Zions Expedition and the Synergy, which are being used, and the Celtic bifurcation have a stepwise improvement in terms of stent strut thickness, and Synergy is the bioabsorbable polymer. So the 9-month composite endpoint, so we've included binary angiographic stenosis. This would be core lab, adjudicated and added in stent thromboses. So meaningful endpoints. Clinical endpoints are 24 months then, as listed, so the usual, and including definite and probable stent thrombosis because of the signal in the complex groups that this may be a disadvantage. And we've started enrolling.
Of course, it's always a question about left main, how we can treat and how we should treat, and also why we treat in one or in other way. Stenting, and if you use especially 2 stents, then it is a restenosis on circ, an ostium of circ. If you use 1 stent, there is no big problem, and that's, of course, we recommend it to use 1 stent if possible, but of course not always is possible. To exchange this 1 drug-eluting stent which goes to circ, ostium of circ, with scaffold. And as you know, we always, we do more than 15-year registry for left main intervention in our institution, and we always use very aggressively pretreatment and plaque modification with cutting balloon. That's always I was guided. But now we try to do a bit a new method and to combine BVS and this for left main intervention. And you should remember that it's of course not like regular 2-stent technique, because this is a synergy plus BVS. This is, if you look on 1-year follow-up, there is a 25 patient. This is 100% follow-up. Death rate 0, cardiac death 0, QMI 0, TVR 4%, TLR 3%. And then you remember that we also not use for 100% a cutting balloon. But if you look on synergy group, there was no any MACEs.